That's it. That's us live. Hello and welcome. This is Time to Talk with Cognitive Sports Therapy. We've had a few weeks off, actually. And I am delighted tonight to be joined by Dr. Louise Price, who's an old friend of mine from GP World, who is a GP with special interest in women's health. Louise, is that right?
Yeah.
And we were just talking before we came on air. So Louise divides her time between running a private menopause clinic, between NHS general practitioning, and also straight to the gynae day.
Yeah.
In St Michael's in Bristol, which is lovely because I had my third child there. And we were talking, Louise, just before we came on, weren't we, just about where we direct this conversation. And I think I felt like it would be really useful for this to be quite a medical conversation, because I'm having other conversations with other practitioners about women's well-being generally. And I think if we can have this conversation be a sort of doctory conversation, I think that's okay, because we know it's not all about the medical side of things. We both appreciate that, but I think we can maybe spend a bit more time on this, you and me.
Yeah.
Is there anything else you'd want to say about yourself and where you're coming to from this conversation?
I think one of the main things to say is how much the landscape has changed in the past 2 or 3 years. So I've been doing women's health for a long time. I've been doing menopause care for a long time. And in the past few years, it has just exploded. And I think that is to do with celebrity input, Davina McCall effect. But, we are seeing, I would find it hard to put a figure on it, but, in the 10 times, if not more, the amount of patients that we were seeing before for, with perimenopausal symptoms, menopausal symptoms, asking about HRT, women at the other end of the spectrum in their 60s and 70s who perhaps missed out on HRT because of the breast cancer scares, and are now saying, should I still have it? Do I still need it? So I think there's conversations, these conversations are happening, and I think it's good to get the facts and to know, to sort of arm yourself as a patient and know what it is, you're going to speak to your doctor about, or the concerns that you have.
For sure. And I think the other thing that is changing, which is great, because I think at the beginning of a lot of the conversations around menopause and HRT was a little bit of a backlash against the NHS system and about GPs maybe not knowing what they were talking about, and a lot of women feeling like they were not being heard and not being listened to and not getting the appropriate treatment and having to reach into the private system. But I think that's changing as well. I don't know if you feel that yourself.
Yeah, it definitely is. I'm sure, as most people know now, there was the big study, the Women's Health Initiative, and because of the data that came out of that, there was a breast cancer risk association with HRT. And actually, as people have looked more and more into the studies, the association is nowhere near as strong as they thought it was. And actually, HRT is far safer than we thought it was in terms of breast risk. And so as a result, this hit all the papers, all the headlines, and women didn't want HRT and GPs didn't want to prescribe it. So there's a sort of 10, 15-year period where GPs weren't prescribing HRT. HRT just wasn't a thing. And so, of course, there's going to be a gap in their knowledge because they haven't been doing it. And general practice is so broad. You're trying to keep up to date with everything that's going on. And actually, you and I both know it's impossible. Ask me about men's health, I'm not your person. Ask me about cardiology, I'm not the right. There's so many areas that, you're less knowledgeable about, perhaps, compared to others. And it's about working as a team in general practice.
I think that's the thing, isn't it? There's always somebody who it's their strength, isn't it? And it's kind of knowing who to direct people to within that practice. I often say to people, if your GP doesn't know, there'll be someone there. Ask who your lead is in a particular topic.
And I think it's important for patients to understand that GPs are so keen to learn and want to be good at what they do. And I think then as soon as the tables turned with HRT, they were there trying to pick up the knowledge, trying to get up to speed with the developments. But there is often a bit of a lag time. And there was a huge demand on the system. And as we all know, the NHS is slightly broken already. And so it's hard to meet that extra demand. And we are trying, but, we will never be perfect.
Yeah, for sure. Maybe we don't go down the politics route, but
down the politics.
How did we get there? But so tonight, I think we were going to start a little bit on menopause, weren't we? As the highlight for the conversation, and I think what I was wondering about was just kind of talking through a woman's journey, I guess, whenever they wonder about menopause. And a lot of the questions I guess I get in clinics and what you probably get as well. So right at the beginning, how do we go about making a diagnosis if a woman is having symptoms and say they are around the age of 40, let's say, and they're starting to get some of these symptoms and they're on social media and they're just wondering when should they be thinking about getting any testing done, and when do they not need to get testing done?
Okay, so by and large, it's a clinical diagnosis. So by that, we mean, you base the diagnosis on somebody's symptoms. So if somebody presents to you over the age of 45 and they've got an irregular cycle, they've got hot flushes, poor sleep, joint aches and pains, irritability, they are perimenopausal. Whatever their blood test shows, they are perimenopausal. Because the blood test goes up and down and up and down. And so you might capture it at one point and it's abnormal, and then you'll capture it a few weeks later and it's normal. And then patients get told, oh, you're not perimenopausal. You actually are. So it's a very symptom-based diagnosis. Women who are less than 45, you might do a blood test for, because you might just want that reassurance because they're a bit on the young side to be perimenopausal. But that being said, I think we are now acknowledging that really the perimenopause starts in your early 40s. And it's a huge spectrum. Some women won't be affected at all. Other women will have severe symptoms. Most of us will fall in the middle. But I think you start to notice in your early 40s that perhaps you're becoming a bit more irritable, that you might get the odd hot flush premenstrually. You might get some joint aches and pains. So it's just being aware that those symptoms might start to creep in. They might not require any treatment, but it's just to be aware of them. I think, as long as when women are informed, we're far better. And if you went to your GP with symptoms like that, they might want to do a blood test.
And there's a bit of a family history, isn't there, in this, to do with what age your mum goes through the menopause and things like that. I often say to people it's worth knowing your family history when it comes to ages, because that earlier tendency tends to run in families, doesn't it, and later, I guess.
Yeah, and you'll find that a lot of women will still be on oral contraception. So if they're on the pill in their early 40s, that's got estrogen in it, so those symptoms will be masked.
Yeah.
So yeah, there's a big variety of presentations.
Or women on the coil and they haven't had any period at all. They don't even know where they're standing in this. And where do we go with that? So if you're on a contraceptive and you're wondering, do they need to come off that contraception to find out, or do you have other recommendations?
So if you're having symptoms and you're on a form of contraception where you're not having periods, apart from the depot injection, which would not give you a reliable result, all the other methods, so the mini pill, the implant, and the Mirena coil, you could have an FSH checked and it should give you a reliable result.
Okay.
But again, I would argue in that early perimenopause where your hormones are all over the place, the result is still not going to be accurate. So there aren't many 40 to 45-year-olds, if they've got a really typical picture, I generally don't do the blood test.
And then we do go into treatment, don't we? And thinking about HRT, and someone under the age of 50, are we saying really that they should be on HRT? They should, shouldn't they? They need that estrogen, they're missing it.
So the average age of menopause is 51. If somebody is, I would say, definitely 45 or below, yes, they definitely need treatment. 40 or below, yes, they definitely need treatment. And the reason I emphasize that so strongly is because we know that estrogen has an effect on your bone. It makes your bone stronger, so it prevents against osteoporosis, and it has a really positive effect on your cardiovascular system. So it delays formation of plaques in your vessels. So it's going to reduce the risk of heart disease and stroke in the future. So absolutely, those women should be on HRT. As you get into your later 40s, if somebody came to me, and I've had this, and I'm sure you have, Claire, somebody in their late 40s, early 50s, and they say, should I be on HRT, doctor? So my initial question is, well, are you having symptoms? No, but I've seen it on telly, and everybody says you should be on HRT now. And my argument there would be, I would never start a medication just because, we think it's good. I would only start it if they're symptomatic.
Okay.
In their late 40s, early 50s, because they've had all the estrogen that they need, really. Interestingly, and this is probably getting a bit too sciencey, I was at the International Menopause Society conference last week in Lisbon, and there was a huge debate we had over the use of HRT for primary cardiovascular prevention.
Yeah.
And there was a room full of 1,000 menopause specialists. And the first question was, who would give HRT for primary prevention? And I would say 95% of people put their hands up, because the evidence is so strong that it has a positive effect on cardiovascular parameters within 10 years of the menopause. So that's, if your average age of menopause is 50, you would need to start it within 10 years of that, or before the age of 60.
Yeah. I mean, I don't know about you, but I've often had that conversation with somebody to do with, so what are your risks, your personal risks from what you can see in your family? My family has Irish genes in there, so cardiac stuff is in there. So certainly that's definitely on my radar. But with someone who maybe had a strong sway towards, I don't know, female cancers, maybe would be less. I'm kind of that's sort of conversations I often have in that spectrum, when it's not as black and white and not symptomatic particularly, and not sure.
100%. And
weighing up your personal risks.
You have to be really systematic about it, and you have to talk about the breast cancer risk. You have to talk about the clotting risk. Like any treatment, there are risks and benefits, and it's weighing it up for that individual patient.
Where do we sit with brain health? In that same room in Lisbon, is there anything? Because I see different things in that to do with dementias, and where do we sit?
So I think at the moment there is no definitive research saying that it is beneficial. It's going to reduce the likelihood of dementia.
Okay.
But within that dementia bracket is obviously vascular dementia.
Yeah.
So actually, one could argue that if you get on it at the right time, it may provide some vascular benefit.
Yeah.
But the jury's out on that one. I would say, I mean, going on to brain function slightly laterally in terms of cognitive symptoms, women will often complain of brain fog, poor memory, word finding difficulties, and the beneficial effects of HRT on those symptoms are phenomenal. And testosterone can often improve those symptoms as well.
Yeah.
I'm sure we'll talk a bit about testosterone. It's not for everybody. It's not the panacea, but there are certain patients who it's very beneficial for.
And that's a good lead into testosterone, because that's always the question. Again, that's sort of the Davina effect. I think there's a lot of people on social media talking about how wonderful it is, but I don't have a great number of patients who've done well on it. I have a lot of people who've really struggled with it and haven't got on with it. What's your take on testosterone?
So testosterone levels fall gradually from probably your early 40s onwards. And then the good news, because there's electron testosterone as well, the good news, the main researchers are saying that actually in your late 60s, early 70s, it starts to rise again. So, you know,
Okay.
there's hope for us all. So your ovaries produce half your body's testosterone. So that as your ovaries fail, your testosterone is going to fall. The main thing that is going to improve your libido and all your other symptoms is estrogen. If we're honest, you know, if you haven't got enough estrogen, testosterone is not going to work. So the main point is replace the estrogen, get that right, and then think about testosterone.
Yeah.
The group of women that are probably going to need and benefit from testosterone are women who have a premature menopause, and by that I mean, you know, women who are less than 40.
Yeah.
They will certainly or almost certainly need testosterone, and women who've had a surgical oophorectomy, because their testosterone levels, rather than gradually falling, sort of fall off a cliff.
Yeah.
So they notice that lack of testosterone, and you find that it works well for those groups. In terms of your sort of general population of women, I see a good response in probably half, if not more, of the women I start on testosterone.
Okay.
It's only licensed for low sexual desire. Women, you know, we talk about testosterone for sex drive, for energy, and for sort of general cognitive well-being. The only research is there for sex drive, but anecdotally, it seems to help with all of those three things.
Yeah.
But you would never start testosterone without measuring somebody's testosterone levels of 300 in index. And then you would repeat those levels to check they haven't gone too high, because the risk with testosterone is causing sort of male side effects. So androgenism. Yeah.
Yeah. Which I think, I don't know whether it puts people off. I see that rarely. I don't know.
Oh, I've never seen it.
It's something we worry about, and GPs generally
yeah.
worry about, but I think it's rare, isn't it?
Yeah.
It's often
the main thing I've seen is where women have put the gel on the same spot again and again and again and again, they can get a localized patch of hair growth.
Yeah.
But apart from that, I really haven't seen any side effects.
Awesome. We're coming to the end of this already, Louise. It kind of goes so fast. I know. We said, because you said to me when I got in touch with you, that one of the things that you're like seeing a lot and dealing with a lot and have become quite passionate about is sort of hormonal mood disturbance.
Yeah.
We wondered if that's a whole other different conversation, but do you want to say something briefly about it here today?
I think it's under recognized, and I think more women suffer with this than we are aware of.
Yeah.
Everybody knows about PMS, but it's a huge spectrum, and it goes from sort of mild PMS to something at the other end that's called PMDD, which is premenstrual dysphoric disorder. And those are women who, in the last 2 weeks of their cycle before their period, cannot function. You know, I've got patients who are bedbound with such bad depression and anxiety, they don't function in those 2 weeks. And then as soon as their period comes, their mood lifts and they function again. So they sort of fit their life and their functioning into those 2 good weeks. And it's amazing treating these women and managing their hormones, how well they respond, and how phenomenal the changes are when they've often had a history of being under the psychiatrist and being on innumerable psychotropic medications that haven't really done the trick.
Yeah.
And there's a really close overlap with psychiatry and women's health here that I think is emerging, but it's early days.
Yeah. So kind of watch this space. I mean, it's that thing. I think there's a group of women who've just put up with symptoms like that over years, haven't they? And they've just sort of labeled it as PMS, and they've just kind of been like, oh, it's me and my mood around my period.
But it's more than that. And these tend to be the women who have suffered with quite severe postnatal depression as well. You can pick out the history. They've had early PMS, they've had postnatal depression, and then perimenopausally, when things really go up and down, that knocks them off.
They struggle again.
Yeah.
Brilliant. Well, maybe again, we can have a proper conversation about that later.
Yeah, I'd love to. Definitely.
A regular slot with you. I'd love it. Thank you so much for coming on. I always say at the end of one of these conversations, it's 15 minutes, so we never can cover the whole topic, but hopefully it's maybe given somebody listening something useful to take away. It never replaces going and seeing your own doctor, but I'm always happy to be contacted afterwards. And if there's anything I can pass on and ask Louise, I will do that. Thank you, Louise. It's been really lovely to catch up with you. And I hope you all have a nice evening. Take care. Bye-bye.